Yes, please, it's on now.
Okay, good evening, everyone. I realize I'm last and I don't want to keep everybody back too long, so I'll try to be quick. Thank you, Alan, for inviting me to present. It's been really educational so far. I think Sadie Ann could probably give my talk. And then, of course, Alan, Malcolm filled in a lot about live donor renal transplantation, which I was asked to speak about. Sadie Ann, I did check for you. You were pretty much almost a perfect match with your brother. So I think you don't have any concerns going forward with your plans. Just for the vaccine, yes, I think we are not yet vaccinating our transplant recipients. I think we're just having some struggles with the hospital, and there have been some patients, some of us who've been vaccinated had some outcomes of more than the chills, vomiting and so on. So I think the nephrologists are just being a little cautious at the moment, but I do agree. I think it's a great thing to prevent COVID going forward, and it is a dead virus. So I think we should be fine. But everything's in flux, but I think we'll get there eventually. So about live donor renal transplantation in Barbados. I think we've all heard this already. Great presentations from Everton about hemodialysis, and we heard from Mr. Hurdle, the nurse, fantastic presentation about the different types, hemo and peritoneal dialysis. And so I just, and Malcolm spoke a lot about kidney transplantation and the fantastic work they're doing in Trinidad. We all know the benefits. We heard it already. This percentage of patients, I think maybe up to 50 at this point in time that we think amongst our population, not as high as Trinidad, we have about 300 on dialysis. We do have a good, strong PD program here in Barbados as well. I think one of the biggest in the Caribbean. And that we think can be transplanted amongst our population. And we're having the same problems everyone else is having. Patients coming on dialysis every week, unfortunately, at the point where they have to get the catheters, as we heard before. We have the two types. Living donors, all we are doing here in Barbados at the moment. We will hopefully someday get to a cataract program as robust as what they have in Trinidad. Different types, we have related, unrelated, and we heard from Malcolm that you can have both related and unrelated and paired. And we also have another type called altruistic. You do have some people who just come out the blue and say they want to do something good for somebody they don't even know. Of course, in that situation, we have to do, somebody's mic is off. I'm hearing a lot of feedback. We do have altruistic donors who just come out the blue and say they want to give a kidney. Those patients, those persons, we tend to give a strong psychiatric evaluation just to make sure nothing strange is going on there. Different types of live ABO compatible is the most common, but they are, because the demand so far outstrips the supply. You do have ABO incompatible, and this is being successful for where I trained in Australia. This was coming on board 10 years ago. I'm pretty sure they must be far with this now. So you don't necessarily have to have that ABO match. You can have incompatible matches. I would say that the immune suppression is pretty strong in these patients, however. Downfalls, it's not a perfect thing. You do need a donor. Living in Barbados right now, maybe at some point deceased, but this is the big holdup for a lot of patients, getting that person who's willing to donate. And I just mentioned, we'll go through a bit later about it's not for everybody. You do have exclusion criteria, and it's not cheap. We heard the insurance companies coming in. Yes, the problem is the insurance companies will only facilitate the recipient if you have insurance, but in our setting, our service is provided to Barbadians free of charge. Of course, taxpayers are paying, so we still have to be cognizant of that, but we know the benefits of transplantations is cost effective. I do agree, the donor, I think it should be incorporated in the whole costing of a transplant. To say to you, I mean, I guess the donor is healthy, but that's part of the process, the donation. So it should be incorporated somehow in the insurance companies covering the costs of the surgeries and the investigations of the donor. What it was our history. We started actually before Trinidad, but then they've gone far past us. Anyhow, so we did our first one in '87, and then we had some up and down as well, similar to Trinidad, to 1995, and then I came back. We did 3. We had 1 death, but the graft was still working. And in our setting, the longest surviving transplant is 21 years. But yes, then we partner with TLC, Transplant Links Charity out of Birmingham, a fantastic charity. They do work all over the world. And they're in the Caribbean and Africa, other places, some parts of Asia. And they just come in, and it's all about skill transfer with them. They just want to come in and help you set your program up, and then they move on and then come back, as Malcolm was saying, just for like high risk ones, pediatric and so on. So with their partnership, we've done about 10 successful transplants. We did have 1 death a year later, unfortunately, in one of our younger patients who died from lymphoma. So we were doing this our twice a year run with them, with the same hand assisted, importantly handing over that laparoscopic hand assisted nephrectomy, which is very, the patients love, much smaller scar. As Sadian was saying, her brother has a tiny scar. And we had a very challenging one last year. A patient had antibody-mediated rejection, which we were able to overcome with plasma exchange. But I would say since COVID, things have slowed down a lot, but we are hoping to get started again this year, especially as we have part of the work of TLC is they also bring surgeons to them to help train. So I do have a fellow in UK now. So when she comes back, we would have 2 surgeons, which is going to be fantastic for our living donor program. And this is TLC. So when they first come, it's a big group. And you can just see Ruth in the background there, the transplant coordinator. There's Dr. Bell, Lisa, Narissa is there as well. Malcolm, he's part of TLC. He came out to help us in the beginning. And Republic Bank, I can't say enough about their support. They support Transplant Links Charity, Barbados, Trinidad, Ghana. This corporate help is really what got us going into something sustainable. We heard Malcolm talking about that. What we want is a sustainable program. And but this corporate help was very important in the beginning. I mean, the government helps, they pay for all the testing and everything, but when it comes to the PR and just getting the awareness, Corporate Barbados really helps. Rotary came on last year as well. That was very helpful. And we do have the Peter Morris Trust. We just reach out to anyone who wants to donate to help us get going with our program. And then we had their patron, Baroness Fliola Benjamin, came last year. And you can see the group is smaller. Just Nick comes as a surgeon now. So initially they bring a big team, and now our nurses are trained. We have a coordinator. We have 2 nephrologists. We have myself and a surgeon in training. So just the lead surgeon comes to give us some oversight and troubleshooting. And then Fliola Benjamin, she's a baroness from the UK, Trinidad roots. She came and did a lot of PR for us. So that was really fantastic when she was here last year. And then, well, I mentioned what we have as far as our services. Since Fliola came, we got our office, which Ruth occupies, and we have a consultation room next door. So that's our little unit. We didn't have that big staffing that they have in Trinidad, but I think we'll get there. So who cannot get a kidney? So, I mean, I think most people can get a kidney. I mean, qualify to be a recipient, but certainly we don't want anybody to have a bad outcome. So hearts, or I think Malcolm mentioned, you get checked, particularly the donor, but the recipient gets checked as well, nobody with malignancy. And because the medications are a lot in that initial period, Sadian mentioned, so you don't want anybody who's non-compliant with meds, who's very dependent on daily care, has heart disease or cancers. You are going to get immune suppressive drugs. So these things we all have to vet before putting someone forward, because it's an operation. So if you're not fit for an operation, you can't be fit for a transplant. So, you know, we have your heart checked, the lungs checked, check to see if you have any cancers, and if you have any mental illnesses. And certainly if you must be compliant with medications. This is a challenge too in the pediatric population, that compliance with the, you know, that initial time, you have like 20 tablets in that initial period. So compliance is very important. What about a donor? Generally, well, for us, we prefer adults with solid organ donation. Certainly we've decided we want over 21 for Barbados, at least for the living donors. I know other countries, it's a little, can we go lower? And definitely, you just heard they have to be checked from top to bottom, so no illnesses. There is an extended criteria. You could be a hypertensive if you're on one medication, because the likelihood of you ending up with, what we don't want is a donor, well, definitely not today, but then also not to end up on dialysis. So we want a very fit person, and BMI should be less than 30. Certainly if you're not there, and when we meet you, we want to encourage you to get there, and it could be a relative, a spouse, or a friend. But every surgery has risk, and then also for the recipient is all those immunosuppressive drugs. So patients have to be aware of the potential risk, and even going forward, the risk of the medications. I mean, some of the medications can make you diabetic, and that has a reality. And then expose you to other infections. So all the challenges that we heard about in terms of staying away from certain areas and high risk, other high risk people have to be taken into account. The initial discussion, so we start with initial discussion and assessment. You see, nephrologist usually reviews you, you go forward into the surgeon, psychologist. I think this is all repetitive. We've been through all the myriad of blood tests, imaging, both for the recipient and the donor. All this has to be done before we can decide whether you are and the tissue typing is important, and the group match, before we decide that a pair can go forward for transplantation. After they've been vetted, then the anesthetist will see them. You heard before. We don't have legislation, but we do have a robust independent assessors group to make sure definitely no money is passing, no coercion. We have, nobody should be forced into giving a kidney. It should be something you do voluntarily, and definitely no money. That is international philosophy, that you should not pay for an organ. I did hear a meeting, because we have now a Caribbean transplant group, and the last summit, there are some countries that are allowing it. I believe they said Iran, where they don't seem to find the ethical challenge. I think if somebody wants to sell their kidney, there are ways that they have that they monitor that. I was surprised to hear, but so I think it's not a universal law that you can't do it. It just depends on the country. But I do think that it's something that it should not be encouraged. This is myself and Dr. Paquette. So after you've been vetted, we take you to the OR, and you get your surgery. And some people don't know, but you end up with 3 kidneys. So we don't take the other 2 ones that are not working out, and we just implant the new one. And I think Malcolm's pictures were much ahead of mine, so I'll gloss over that. Sadie, I mentioned the post-op, the donor doesn't stay in very long. They go back to the ward, the recipient goes to ICU, and then close follow-up in the post-operative period. And we follow up the donor lifelong, as well as the recipient. So the concerns about their health really, actually, I think donors have been shown to live longer than the average person, because there's such follow-up and they're such healthy people going into the process. And this is Glenn and Martin post-op. You see how happy they are, smiling in that initial post-op period. This is a picture I took from the newspaper. And there is the size of the scar, very small. And the patient's likely hand-assisted donor nephrectomies. And there's Floella with another one. I see Pam just came up there. She and her daughter did a lot of PR for us. And there's me with Sadie and Nick. I caught her coming to the ward for some review at some point, because the transplanting star, they have a Facebook page and a website. They love to show pictures of the patients that they have come across to help us with. Just to give I think we're doing well. Everybody knows about kidney donation in this country. I did a study a few years ago, and this was the size of the pie chart, people who knew about it. But as you can see, as we start talking about, are you considering it, the percentage goes lower. And then are you planning to talk to your family, the percentage goes lower. So this is what we need to work on to get more donors. And then asking, that's the biggest drop. So people don't want to ask. I always say it's a time to be selfish. So you need to ask someone to donate to you, and then let's get going with the workup. I know it's a big ask, but I think you put yourself in your position of if it were you, would you have given? So if you think that the answer is yes, we'll go ahead and ask. I can't say enough about the cost savings. I think Malcolm alluded to that very strongly. Definitely cheaper, more cost effective to be transplanted than on dialysis. But I mean, if you don't have a donor, we heard how you can live quite comfortably on dialysis if that's the case. Future, well, we want the legal framework. We are getting there. We definitely had it passed. It was put to cabinet last year and they are fully on board. We just have to get we have given strong input into the draft legislation. So we just need I believe who it is, the Parliamentary Council has to submit that legislation then to put it into law. So this has started in Barbados and has started in Guyana too. So since we had a meeting in Cuba with the Caribbean and Latin America, we have had a lot more camaraderie with the Caribbean islands. So we kind of know what's happening in most of the West Indian islands, including Jamaica as well. So Trinidad, Jamaica, Guyana has started their move with the legislation as well, and so have we. And maybe going forward, we can get some organ sharing across the Caribbean. That would be fantastic with a few units in Trinidad, Barbados, Guyana, Jamaica, and that have the capabilities. It would definitely be a great thing for us. Period exchange that Malcolm alluded to, and all these things can happen. And once we just get over COVID, I think we can get going again on what we need to do. Living will is a challenge for us here because they're not recognized. So like, for instance, if we do get the brain death legislation, we need to get the living will sorted out as well. So you can't legally leave your organs. We would still want the opt-in, so the relatives would have to give consent. That is part of our draft legislation as well. We need more staff. We would definitely need in-house tissue typing. Certainly if we get the legislation going, we're going to speak to Trinidad and give us some input as to how they're set things up down there. And as I mentioned, we have a second surgeon getting trained, and we also have a nephrologist who's finishing her fellowship. So hopefully we'll have 3 quite soon. So in conclusion, better quality of life, I think Sadie Ann couldn't sell it better for us, as she mentioned, and lower costs. So I want to thank everyone for allowing me to present, and I'll take any questions at this time. I don't know if people might be ready for dinner. Thank you.
Dr. O'Shea, question, can a lupus patient have a transplant?
Yes, a lupus patient can have a transplant once you're quiescent for about 2 years or so. You can't have active lupus, but once we are satisfied that your lupus is under control, you can have a transplant.
Margaret, thank you.
What I can say to that lady who just asked is that Anne-Marie, who is our coordinator, who's had a baby, she had lupus nephritis. So yes, absolutely.
There you go. Okay.
So Dr. O'Shea, Dr. Samuel, is it safe to say for us as nephrology nurses, right, that because I mean, we always have this conversation with the patients in terms of letting them know the importance of compliance, because compliance is not only for their health now while on dialysis, but if it is that they are seriously looking at transplantation, compliance is essential, because some of them have the idea, I get a transplant and I'm home free. There's nothing else to do. I'm living life happy. And we're trying to show them, yes, you'll be a bit freer, but at the same time, you still have to be compliant because you still have medications to take. So, I think that for us as nurses, my take home from this definitely is that I'll continue to let them know, listen, you have to be compliant for your health to live longer on dialysis, or even if you're looking at transplantation, you have to continue to be compliant with your medication.
Yeah, 100%. If you can't miss, you have to be that kind of strict person. I mean, patients like Sadie Ann and Pamela or Evidence and Glenn, I'm not sure I saw Glenn on the call, but yeah, you have to be that determined, driven person and very responsible. It's because you have to, if you miss on a medication, you lose a kidney. So that's really important. And all that is, we vet all of that in the pre-op process as much as we can, but you will get people who then, especially the children.
Well, if I can throw my hat in the ring here because of our experience with pediatric cases. our greatest problem is with our pediatric patients has been compliance. We have done 10, and of those 10, we only have 3 who are now still surviving. We have lost 3 young women who were 11, 12, and by the time they were 16, 17, 18, they just went to pot, and it was like, and they're not back on dialysis. We had an unfortunate young man who 2 years after he was transplanted, he became pretty rebellious, and he died late last year. So yes, compliance has to be strict, but it is much more of a problem with the younger patients than the older patients. You cannot emphasize enough the fact that these people, they have to be compliant, and while they will feel so much better, you still have to be disciplined in everything you do.
Dr. O'Shea.
Let's say I was told to take that medication for the transplant at 10 o'clock. And then I forgot to take that medication. I take it 4 o'clock in the evening. What happened?
I don't think 6 hours is going to be that huge. Somebody's asking if you can go without it for 1 or 2 days. It depends on the half-life. So if the medication starts to drift, because I mean, every tablet, you know, if it's like it lasts about 24 hours in the body, and don't forget, you have more than one that is supplementing you. So you would have some steroid, you will have the tacrolimus, and so this is more than one. But we have fasted patients, you know, if it needs that they need to take it orally for days, if they have to get surgery for something else. So 1 or 2 days, you're not going to see a rejection at that point. I think like going beyond, like, you know, up to 4 or 5 days, then you'll have a problem.
Dr. O'Shea.
Yes, sir.
A question. Will you recommend a person 65 years and over for transplant?
To receive one?
Yes, ma'am.
Yes, definitely.
Okay. So if I'm 60, at present I'm 68 years old, you recommend I get one?
Well, the age is not so much the issue. You have to get all your checks. So if your heart is good, your lungs are good, your vessels are good. The age, you know, as people say, age is a number.
Okay, thank you.
I just see Mrs. Branca said her husband got his at 70, and he's doing well.
Well,
okay, I know he's doing well, yeah. But thank you.
I did one in November on a 72-year-old who is doing very well now. So as Margaret says, you have to be thoroughly checked. And once you achieve certain standards in that checks, mainly cardiovascular and your vascular system in terms of implanting the kidney, then you're good to go. So age is relative. It's not so much your biological age, but your physiological age.
Physiological age, yeah.
As my colleagues here like to say, your protoplasm. You know, if your protoplasm is bad, then forget it. But once you have good protoplasm, doesn't matter. Your age is not a limiting factor.
Yeah. I think that's.
All right, guys, I think that brings us to the end of all of our presentations.